Hello, good evening, everyone. I'm being joined by Dr. Smikle, who is the Medical Director of Laurel Fertility Care, a boutique fertility clinic in San Francisco. And we are going to talk all about PCOS. So any questions you have for him, please don't hesitate to ask. We will be talking about diagnosis, symptoms, treatment options, pregnancy success rates, all sorts of different things. So please have your questions ready. He's here now. Hi to those who are joining. Welcome. Good evening. Good afternoon, Dr. Smikle. How are you?
I'm doing okay. Good. I'm doing okay. Thank you for inviting me back to your podcast.
Well, this is a great conversation we're going to have today because it's PCOS Awareness Month coming to an end now, but obviously we want to continue the conversation and the awareness around it. So for anyone who's joining, please could you explain what PCOS means, what it is, and then we'll talk a bit about fertility related to that as well.
Okay. Well, PCOS or polycystic ovarian syndrome is a spectrum of disorders that a lot of women have. The incidence ranges from about, let's say, 10 to 15% to up to 40% of women will actually have some of these features. It is a constellation of disorders, so therefore patients may end up having irregularities in their menstrual cycles, increased hair growth, increased male type hormone levels. You may end up having infertility. Sometimes you'll end up having thyroid disorders as well. So those are the common things, but one thing that some patients ask is just that, does all those things mean you have PCO? And if you have these multicystic ovary appearances on ultrasound, does that mean you automatically have PCO? So therefore, that's one of the things that we can kind of talk about during the conversation today.
Great. And yes, so this is all about debunking the myths associated with it as well. So for someone who may be wondering whether that might be their diagnosis, what are the common traits that you'd see with symptoms for PCO or PCOS?
Well, it depends on the patient's age and also their body habitus and their menstrual pattern. So therefore, first, the classical distinction of PCOS would be someone who is overweight, who is on ultrasound has that pearl necklace appearing ring of pearls on ovary on ultrasound. They may end up having hyperandrogenism, and that's one of the common things associated with it. There was what they call a Rotterdam.
Explaining to people who may not know what that is exactly?
So basically, increased hair growth. So therefore, patients will end up having increased hair, facial hair, abdominal hair, hair around the nipples. So those are the common features. Some people will actually have hair all over. And there are some genetic dispositions where you end up having some patients who are from, say from South America, where they end up having a large familial concentration of patients with PCO. So therefore, they end up having all those features. Yeah. But it does vary from individual, and it's not always going to be inherited. It's important to know.
Do you have patients who come to you who may have been misdiagnosed with something else before PCOS is diagnosed?
One of the things that you may guess, to answer your question directly, many times patients with hyperinsulinism because of diabetes will end up having irregularities in their menstrual cycles. And so, although some patients with PCO will have hyperandrogenism, patients who are diabetic will also have the same thing, and so therefore they'll end up on the same spectrum. Those individuals may not have that pearl string necklace on ultrasound and may end up having some irregularities in their menstrual cycles, but if their diabetes is managed, then they'll have better control. So therefore, that's one important thing. There are patients who presume because they may be overweight that they have PCO, and therefore you do an ultrasound and there's actually very few follicles on the ovaries, and it may just be there's something else underlying their menstrual irregularity. So therefore, you do need many of those constellation of traits in order to diagnose someone with PCO. Not everyone who has hyperinsulinemia, nor anyone who has an elevation in their thyroid hormone is going to have PCO, but it's a spectrum that it's a large circle, and some patients within that group may end up having PCO. Others who are actually not and don't have all those features may end up having some of those phenotypes, but not have the spectrum and not fall into that disorder.
And how many women are typically diagnosed with PCO?
In different populations, it can be pretty high. Again, looking at that South American population, you'd end up having a pretty high percentage, up to 40% of patients actually having it. If you're looking at a different population, say like in Scandinavia, or if you're looking in say, a North American community, you may end up having 10 or 15%. So the incidence does vary depending on location and depending on their genotype.
Okay. Someone has just asked, whilst you were talking about it just now, about hair growth. Is there anything people can do to manage that?
So in terms of abnormal hair growth, because of the pattern, what patients with PCO may notice is that they'll end up having a lot of hair, you'll end up having hair growth, and then you may end up having hair loss because there's a rapid turnover in hair production and loss. And so managing that, you can end up using agents to slow down that loss, using medications like finasteride or spironolactone. Those are ones that you can commonly use. That'll also treat the acne that's associated with PCO, and also increase it'll decrease the male type hormones that are inside the ovary. And those are the common things that you can typically use to manage those. The question patients ask is just that, can you take those medicines and try to get pregnant? And unfortunately, the answer is no. So you either try to manage some of the symptoms patients have related to PCO, and you're not trying to get pregnant, or you're trying to get pregnant. The two are not going to be on the same pattern.
And so for people who are trying to conceive, obviously that's the burning question today. Does it cause difficulty? Obviously, if you can't pinpoint ovulation because ovulation may not be happening, what can you do to improve your chances of success naturally and with treatment?
So because of the association with hyperinsulinemia, one of the things that patients commonly will do on their own would be to start restricting glucose and restricting carbohydrates. And that does have some effect. It may not be the only thing that's there. All patients have also considered using myoinositol, which is another insulin-lowering agent that people have heard about. And those have some effect. They may not have effect on their own, but that's something you can do on your own without really seeing a physician. But many times, if those things don't work, the other thing is weight loss. Some patients will try to lose weight, and that'll help. For patients who are thin and who have PCO, then actually that's not going to be something that's effective because they're already thin. Losing more weight is not going to be effective. So those patients are the ones that we're going to coming into our office to see, to manage those symptoms and to basically try to get pregnant.
And so what would you do to manage those symptoms? How would you treat someone who walks in and has that diagnosis, or does it depend on that person and their weight and everything you've just mentioned?
Once you've actually gone through and evaluated, making sure that they don't have diabetes, making sure that hypothyroidism is corrected, all those things, and making sure that all the other profiles are actually managed, then you need to have those patients ovulate. So typically you'll use oral agents, metformin, clomiphene citrate, or letrozole are the ones most commonly used. Outside the United States, people have used tamoxifen. Patients have used other agents. Other physicians have prescribed those. In the United States and most of Europe, most of the medication being used are going to be either letrozole, which is Femera, and clomiphene citrate. Those are the two ones. They may also consider using gonadotropins to stimulate the ovaries. The challenge, though, is that patients with PCO may end up having a hyper response to gonadotropins. So it's something that it does require frequent monitoring in order to basically treat the patients with PCO. And then that's one of the reasons why patients, if they're unsuccessful using oral agents, often will end up going through something like IVF, because that's where you can truly manage everything by removing those eggs, fertilizing them, and then transferring the embryos.
So, do you think that it is a bit of a myth that people may go into it or have a diagnosis and think, I can't get pregnant because I've been diagnosed with PCOS?
That is a great point. And I think one of the things that patients often will hear is that, you have PCO, you're either going to get pregnant and miscarry, or you're never going to get pregnant at all. And that's one of the things to kind of truly, help patients through that conversation, because many times it relates to whatever is underlying that needs to be corrected. Often, if those are corrected, meaning that, let's say they have hyperinsulinemia, then using something like metformin in conjunction with clomiphene or letrozole or gonadotropins, those will help those patients, manage the underlying issues that may cause them to miscarry and help them to be successful. So yes, there's a lot of things that you can do to manage those things in helping to have them be successful.
Mm-hmm. And do a large chunk of people with PCOS who come for treatment or to get investigated, do they end up needing to have IVF, or can some of them conceive without it?
Many will actually conceive without IVF. If you can make them ovulate, then that'll actually be one thing that'll be helpful. And the consistency in that ovulation is going to be something to work with. And sometimes patients get frustrated because it's a long time since they've been trying, and patience is something that it may be short given the fact that they've been trying for some time. But if patients are being able to allow themselves a time to be successful, and you're getting 5 to 6 ovulatory cycles, many of those patients, depending on their age, may be successful. Still, older patients with PCO, it's often better just to move directly to IVF, because time is the part that's going to be the critical part to overcome. So that's the thing you have to kind of then consider.
When you say older, what age bracket would you be talking about?
I'd say that, in patients who are over 38, then I'd say probably moving on directly to IVF may be a more pragmatic way to manage things. The reason for that is just that, let's say it takes 3 or 4 cycles in order for them to actually become ovulatory. Then it takes 5 to 6 cycles in order to then ovulate. Then that 38-year-old may be closer to 30, 39, or maybe even 40 by the time they're actually trying they're on that path and having to consider IVF. Moving to IVF, they'll end up having eggs, removed and then fertilized. They have a much better chance in terms of getting pregnant. They have a much better chance in terms of being, managed. And they can actually freeze embryos, so therefore, if they're planning a second or third child, they can also be successful later without really the effective age.
That's very useful to know. Thank you. What about for someone who might have secondary infertility and they didn't have this problem the first time around and have been recently diagnosed?
That patient, I'd say, I would probably be much more tolerant in terms of basically, moving on that slower path, especially if they only want one more child, because, that person, if they're going through, even if they're 38, they may get them to ovulate and then they'll be successful. They still need to be managed and related to the fact of age in terms of, going through genetic counseling and everything else, because they can't overcome that part of it. But at the same time, they have a really good chance in terms of being successful. So therefore, that'll be something to consider. So not everybody has to go on to IVF.
And someone has just asked about glucose levels. We will come on to the questions in a minute, so thank you for being patient. In terms of nutrition, what can people do to support their lifestyle and their bodies whilst seeing someone like you to have investigations and to have treatment if they need it?
I think the biggest thing to take away from this, and from a dietary standpoint, is simply managing, or not overindulging in carbohydrates or glucose. So anyone, whether PCO or not, if you're overindulging any habits, then that can contribute to the success. But specifically for patients with PCO, PCOS, the important thing is that carbohydrates are going to be one thing that may actually be a downfall. So simply trying to restrict or tailor a diet so therefore you're modifying the intake and maintaining a steady intake is going to be important. One thing to realize is that the body does not like a seesaw or a push-pull type effect. So therefore consistency is going to be a whole lot better in terms of managing, rather than actually having, bouts and different effects.
Mm-hmm. Yeah, absolutely. It's like yo-yo dieting, isn't it? Sometimes you can end up
Yes.
putting on more weight at the end of a fad diet than before.
Exactly. And that's the thing to kind of maintain. So, the key thing is just that the goal is to get through getting pregnant and then planning beyond the pregnancy, because there are going to be increased rates of weight gain with pregnancy and then a harder loss afterwards. So those things all have to be considered as part of the process.
Excellent advice. Thank you, Dr. Schmeichel. So we have some questions. Let me just check
Mhm.
back. Someone asked, we've talked about hair growth. And what type? Oh, we just talked about lifestyle. So is there anything that you can help with, kind of supplements, sleep, reducing alcohol intake? All, is it all the regular things you would do to support fertility anyway, or is there anything above and beyond for PCOS?
I don't think there are anything specific to PCOS other than it's much, much more restrictive in terms of managing your glucose intake rather than anything else. That's probably much more pragmatic to consider that as an effect than anything else. Using supplements, one of the things to consider if you're on, and this comes up often in terms of patients who started the minoxidil on their own and then they're coming into the clinic, and we may say, well, the thing to do is to consider going on metformin versus continuing on the minoxidil, only because it's harder to kind of manage the effect with the minoxidil versus going through, and you can increase the dose of metformin, or you can regulate that effect more directly. So therefore, that's one of the things to kind of look at in terms of looking at talking with your physicians. Many times patients will say, well, if you're on metformin, is that the only thing you need to be on? And for a small segment of patients, that may be sufficient for a short course. But, there's a number of studies to show that, getting someone to ovulate is going to be a whole lot more effective. And metformin is not a means for getting you to ovulate. It's a means specifically to lower their glucose levels. So it's something where you can use metformin as an adjunct to using clomiphene or letrozole, but you're going to need something to get you to ovulate. Metformin by itself will not.
Okay, thank you for that. And Donor Concierge asks, can women with PCOS still be egg donors?
Yes, and I'd say that there is they tend to make more eggs, and depending on the embryos, they may end up having a lot of embryos as well. So they may be a good source for eggs for a donor cycle. Typically, they'll end up having a higher risk for having a lot of the consequences in terms of ovarian hyperstimulation syndrome. So therefore, they need to be monitored carefully. But yes, patients with PCO can be egg donors, and they are used as well.
So is that a positive thing for people who have PCOS who might be having IVF, that they produce lots of eggs, or is it really a positive thing?
No, it's good that they'll end up having lots of eggs. The downside is just that there is a situation where you may end up having too many eggs.
Right.
That puts you at greater risk for having complications, and more importantly, oftentimes patients who are with PCOS who are going through an IVF cycle, if you're starting to lower the dose of medicines during stimulation, that can have an impact on egg quality. And so therefore you'll end up having someone who makes lots and lots of eggs, but end up having poor quality because of the concerns of decreasing, as I would say this, a patient, you're having, you're fertilizing a garden, and if you decrease the amount of fertilization to that garden, then you're going to end up diminishing the overall growth of everything within the garden. Therefore, if you're decreasing the stimulation of the ovaries by decreasing the stimulation hormones, you're going to have an effect on the eggs themselves. So you may end up having fewer eggs, and then for someone who's going through may still do well, but especially if you're looking, say, like an egg donor, where you want many of those eggs to be mature and useful, then you may end up having some impact. So you will have some lowering during stimulation in some patients, and that may be fine. It's just not something that we would want to do. Consistency is going to be a better approach.
Totally makes sense. Someone's asked, does staccato, is that the right word? Slow release metformin work in the same way for PCOS? I don't know if I pronounced that.
I'll be honest to say that I haven't used or I'm not aware of the effect it has, so I can't really speak to that directly. So, it's something that I'll probably end up having to research and figure out some more. But it's not something that, basically any of my patients have actually asked me directly about, so I can't speak to that directly.
Okay. And I've just had a private question come through asking, is it true that inositol, I need that differently to me, can help with managing symptoms of PCOS?
That's the minoxidil, so yes.
Yeah,
So
yes.
therefore, that's the one that people talked about as far as dietary supplements and everything else. So it acts the same way in terms of reducing insulin. So yes, it can help with patients with PCO.
Does it also help with egg quality as well?
That's a more challenging one because essentially there's no direct studies to show that it has a direct impact on egg quality. Most times when patients are going through IVF cycles, they're either switching to other agents, and so they're not strictly on minoxidil by itself. So it's harder to control, and there's not really any studies that I know of that basically correlates that basically it helps egg quality. Patients with PCO will end up having lots of eggs, and if there's decreasing hormone levels, as we talked about before,
Yeah.
then that may impact egg quality. So it's not the minoxidil itself, no.
Okay. Someone has just asked, starting IVF soon. I asked my fertility specialist about supplements. He advised that I should stay on metformin and folic acid only. I'm torn. Is it enough?
I'd say that depending on your age, that may be sufficient. So therefore, it's something to kind of consider. I'd say that the other thing too is, maintaining, continuing on CoQ10, which is one of the things that it doesn't really do any harm, and that's important. It's more useful in someone who has a lot fewer eggs. So therefore, that's one of the things in terms of if they're talking about specifically PCOS, it may not have as much of an impact. So therefore, there's not a need. But I'd say the metformin is going to be an important one. If there's one thing to stay on, I would say that's one of the things to consider during an IVF cycle.
Great, thank you. I hope that answers the question. Does anyone else have any more? She said that her AMH is high. Does anyone else have any more questions for Dr. Smikle? Well, we've got him. We're talking tonight about debunking PCOS myths. Is there anything else that you want to add to this topic, Dr. Smikle, that you think might be helpful for people?
I think the important thing to kind of leave your audience with is to realize that first, PCOS, it's not a sentence that basically means that you're not going to be able to have your family, and that's an important thing to realize. It does take some effort and does take some finesse in terms of managing and improving, the eggs embryo quality in terms of someone who's going through a cycle. So those are things to kind of pay attention to. I do think it's important to kind of have or talk to someone who's at least a lot more cogent in terms of working with patients with PCO to get a better success, and that's an important factor. But importantly, to realize that you should have that potential, and you should actually be able to have your family. So you shouldn't say you shouldn't write yourself off for having PCO. That's important thing to know.
Great advice, and things like Awareness Month helps, don't they? For
Exactly.
people to realize they're not the only ones with this diagnosis.
Correct. Correct.
Last question: is it possible to be diagnosed with PCOS with a regular cycle but with a high AMH?
It's yes, especially in someone who's thinner, or that on ultrasound you'll see that ring of the pearl of eggs on the ovary. So therefore, that's one of the things you'll see. And if that patient then gained weight, they may end up having irregularities in their period. So yes, especially in terms of patients working out all the time, it's something we see more often now. And then if you look really carefully, they'll also have a lot of the other underlying issues, LH-FSH ratios, and things that you may actually not really think about.
Okay, thank you so much, Dr. Smikle. And you've got an event coming up, haven't you? This isn't for PCOS, but this is around fertility preservation. Can you tell us a bit more about that?
Well, this pandemic's been quite a bit for everyone, and so therefore it's been a challenge in terms of basically hosting events. And I think in San Francisco we're fortunate that majority of our the population is now vaccinated. So we're hosting an event that is an in-person event for patients to come in and see and understand their fertility options and talk about fertility preservation directly. So hoping to go back to pre-pandemic efforts in terms of meeting, talking to patients directly. So that'll be our first event since the last 2 years.
Amazing. It sounds incredible. So I'll put the link to it in the bio so people can check it out. Can people join virtually if they're not in the Bay Area?
I'm pretty sure that we're trying to set it up so it can be streamed virtually. So everyone, one of the things they did learn from the pandemic is just that everything's virtual now. So
Yeah,
yes, we're hosting
exactly.
everything that way.
Absolutely. Well, thank you so much, Dr. Schmeichel. It's been fascinating as always. I hope everyone has found it useful. I'm sure they have. Really appreciate your time today. So thank you.
And thank you again for the invitation. So we'll continue to be here whenever you'd like us to.
Absolutely. Thanks everyone for joining. Bye bye. Have a good
Okay.
day. Bye.
Bye now.